This lecture is a continuation of hypocalcemia, and it will be on the remaining causes of hypocalcemia. Chronic renal failure causes hypocalcemia in non-horse species by at least two mechanisms. The first mechanism of hypocalcemia is vitamin D deficiency or hypovitaminosis D. This is because vitamin D is converted to its most active form by the kidney. With chronic renal failure, there is a decreased renal functional mass and therefore decreased conversion of vitamin D to its active form. Horses do not depend on vitamin D for calcium absorption by the intestines, so they do not develop hypocalcemia with chronic renal failure. The second mechanism for hypocalcemia is decreased GFR, resulting in hyperphosphatemia. The hyperphosphatemia may be so severe that it results in metastatic mineralization, and I'll abbreviate that MM. And this metastatic mineralization will be further explained on a subsequent slide. Other changes that may be seen with chronic renal failure include non-regenerative anemia due to an EPO deficiency, renal azotemia due to decreased GFR, hypoalbuminemia due to a protein-losing nephropathy, and renal electrolyte loss. Hypocalcemia due to hypoalbuminemia is the most common cause of hypocalcemia. The total calcium concentration consists of three forms, which are the free or ionized calcium, the protein-bound calcium, and the non-protein-bound calcium. The total calcium concentration is measured by a chemistry analyzer. Therefore, that is the measurement that we routinely measure and report. However, the free or ionized calcium fraction is the metabolically active form, but it's not routinely measured. It's measured by a blood gas instrument. But this is the form that's under hormonal control. When hypoalbuminemia is present, the corrected calcium concentration can be used to determine if the hypocalcemia is due to the hypoalbuminemia. If the corrected calcium concentration returns the calcium to within its reference interval, then that suggests that the hypocalcemia is completely due to the hypoalbuminemia. However, this should only be used as a crude estimate, and measurement of the free calcium concentration should be performed if the true calcium status of the patient needs to be known. Using an inappropriate anticoagulant to obtain the blood sample can cause a false hypocalcemia in vitro. EDTA and citrate anticoagulants inhibit coagulation by binding calcium. This anticoagulant-bound calcium is not measured by the chemistry analyzer. If potassium EDTA is used, then you can also see a false increase in the potassium result. Hypocalcemia due to intestinal disease or decreased intake most commonly occurs in horses compared to other species, and this is because intestinal absorption of calcium in horses is primarily dependent on dietary intake and intestinal health, and not on vitamin D. With low calcium diets or decreased intake, Non-horse species can compensate by increasing vitamin D calcium absorption. Other clinicopathologic abnormalities that you may see are variable, and it depends on the underlying disorder of the horse. Metastatic mineralization may occur in any animal with hyperphosphatemia. However, prolonged and significant hyperphosphatemia most commonly occurs with chronic renal failure. Metastatic mineralization occurs whenever the calcium and phosphorus product is greater than 70. When the product is greater than 70, then calcium and phosphorus bind to one another and precipitate out of solution. These calcium-phosphorus complexes deposit in the tissues, causing tissue damage and potentially organ failure. In this picture, there is a mineralized renal tubular epithelial cell from a dog with chronic renal failure. Maternal hypocalcemia is seen in the periparturient period, and it is due to calcium utilization for fetal mineralization or calcium excretion by the mammary gland during peak lactation. Maternal-associated hypocalcemia has a variety of names, including milk fever, eclampsia, and periparturient hypocalcemia. Since phosphorus is also used in fetal mineralization and is also excreted in milk, hypophosphatemia may also occur, but phosphorus may also be normal. Large animals with milk fever tend to have hypermagnesemia, which will be further discussed in the magnesium lecture.